Good afternoon. Welcome to this Global Health Unpacked seminar, which is being hosted here at the Center for Development and the Environment at the University of Oslo. My name is Katarina Storing, and I lead the Global Health Politics Research Group that organizes the seminar. And today we're very delighted to be able to introduce Professor Simon Rushton, who is visiting researcher at our center this month from the University of Sheffield. Simon joined the Department for Politics and International Relations at Sheffield more than a decade ago, but was a couple of years ago promoted to Professor of International Politics there, and is now the Director of Research and Innovation. And his research interests focus on the global politics of health, peace, and conflict, and also on participatory research methods. And his work has looked in particular at international responses to infectious diseases and the links between health and national security. And he has done seminal work on the global architecture of governance for health and healthcare delivery and conflict and other crisis situations. And his current research projects are in Nepal and Colombia. And in fact, he came back from Nepal just last week. And this is what he'll be talking to us about today. The title of his talk is The Health System Consequences of Constitutional Change, Insights from Nepal. And the big question that we'll be looking at is, can a new constitution really impact health? So the way we're going to run this is that Simon is going to talk to us about this topic for about half an hour. And then afterwards, we will open up to questions and comments from the audience. We have a live audience here in Oslo and also quite a few people online. So I think you can pose your questions through the Q&A if you're following us online. And then Simon will moderate that discussion on his own with some help from colleagues here. So please, Simon, welcome, and thank you very much for coming.
Thank you, Katarina, and well, thank you to those of you in the room for coming, and also to those of you online for coming. We've got quite a mixed audience today, and I've seen who's online, which includes some of the colleagues from the project that I'm going to be talking about. So any difficult questions that come from in the room or from the people online, I'll ask my colleagues to weigh in if there's any that I can't answer. If you just give me a moment, I'm just going to try and share my screen. There we are. Yeah, I'll do that. Don't need to go full screen there. There we are. Great. So hopefully you can hear online, and hopefully you can all see my slides online. I'm going to talk for maximum 30 minutes because we want to leave some time for questions from those in the room and for those online. And what I want to do today, knowing it's quite a mixed audience, is talk a little bit, as Katarina said in her introduction, about relatively recent, a little bit of time ago now, constitutional change in Nepal, thinking about how that's impacted on the health system and in health more broadly. But I thought for those of you who are perhaps less interested in the kind of empirical detail of that, I'll also try and talk a little bit about some of the methods that we've been using in this project, in particular focusing on participatory policy analysis as one of the kind of core methods that we've been using to try and understand what the impact of this constitutional change has been. I should also say from the very beginning that I'm talking here on behalf of a very large team. This is a project which I'll tell you more about later. This is most of the team on this picture. It's not actually all of the team. We never managed to all get together in exactly the same place at exactly the same time. But there were about 20 something of us in the team. And it was a team which myself and my colleague Julie Bellin, who you can see waving her hands and pulling a funny face, had the pleasure of leading. But the vast majority of the team were based in Nepal and are Nepali scholars. And what I'm talking about today is not all work that I've done. It's work that we've done collectively as a team. So I certainly want to make sure that the credit for most of this good work goes to the people who've actually done it rather than to me. Just very briefly, what am I going to talk about? I'm going to talk a little bit about the link between constitutions and health, and I think we're doing that in a slightly different way to most of the existing literature, and I'll point that out. For those of you not familiar with Nepal, I'll give you a very brief rundown on this transition to federalism that's happened over the last slightly less than a decade and is still very much ongoing. I'll talk a little bit about our project, but I won't give a lot of detail. Very happy to answer any questions on that later. And then I suppose the two main parts of what I want to do is first of all give you a kind of necessarily quite brief and high level overview of some of the things that we found about how this constitutional change has impacted on the health system. And then, as I said, also to spend some time thinking about methods and to thinking about the ways in which we've tried to use in this project participatory policy analysis, both as a method of data collection, but also as a way of kind of co-producing policy recommendations and indeed kind of direct interventions in the health system. So for those of you less interested in the empirics, hopefully you'll be interested in the methods and vice versa. And there may even be one or two people interested in both. Well, yeah, we never know. Good. Okay, so constitutions and health. There's not actually huge literature on constitutions and health, which is quite surprising when you think that we all know, presumably on this call, that politics is fundamental to health. The ways in which we organise our political systems are fundamental to health in all kinds of different ways, whether that be on the kind of social, economic determinants of health, whether that be on the ways in which health care is delivered, whatever it might be. What work there is tends to be much more framed around the right to health. So there's quite a bit of, especially legal literature, for example, about does it make a difference if you enshrine the right to health in your constitution? Does that actually improve health of people or improve people's ability to access health services and so on? We found at the start of this project there's actually very, very little work that looks at how constitutional changes might impact on health and on health systems. Probably that's because those kind of big constitutional changes like the one I'm going to talk to you about today don't happen that often, right? It's not very often actually that countries completely reinvent their political systems. What we see much more often are more limited processes. So there's a big literature, for example, on health system reform. Clearly, there's a big literature on decentralization of health systems, and that's been quite a big trend over recent decades. My colleague Sujata Sapkota, who I saw is on the call, led a review which we recently published of that literature, which is looking at the kind of benefits and costs of decentralization of health systems. But actually what we see in the case I'm going to talk to you about today is a decentralization of a health system, but it's one that's not like those other processes in some crucial respects. And I'll talk more about this later, but as a preview, it's not like those other cases, because what we saw happening in Nepal wasn't actually about the health system at all, right? What this was actually a bigger political reorganization as a result of a new constitutional settlement. And the health system was kind of collateral in that process. So it wasn't done for the benefit of the health system, but the health system nevertheless had to kind of adapt to that new constitutional structure. Okay, some of you will know a lot about Nepal's move to federalism. Some of you may know less, but I'm going to give you a very brief rundown for those of you who don't know. You will probably all know about the civil conflict in Nepal, which went for 10 years from the mid-1990s to 2006. There was then an interim constitution and a long process, almost a decade, of working out what the new constitution for the country was going to be. That was a very protracted process. We don't have time here to get into all that history, but it is quite an interesting history. What we do have time to say is finally in 2015, what we get is a brand new constitution, which completely changes the government structure of the country. So the monarchy is already abolished at the end of the Civil War, but what we get is a transition from what was actually quite a highly centralized system to a new federal democratic system. That brings structural changes, which are really important. So you get the creation of new provinces, hadn't existed before, 7 new provinces, each of which then has its own parliament, has its own capital, is responsible for policy making and so on. We'll come on to that. And a new local tier of government, new municipalities, some of them designated in various ways, but rural municipalities, urban municipalities, and so on. And again, elections at the local level. So the 2017 local elections in Nepal were the first locally elected governments for 20 odd years. So you get a kind of democratization of local government at the same time. So you get both a structural change, but also a kind of greater degree of democratic control over decision making. So that's really important kind of background context. What does the new constitution say about health? I'm not going to go into this too much, but it does, just reflecting on that literature, does enshrine the right to healthcare. And I won't read all this out, but you can see some of the constitutional provisions that that guarantee the right to basic healthcare services, et cetera, equal access to health. So that is in there, and that's, you know, we can talk about that later in Q&A if people are interested, but that's not the bit I want to focus on today, actually. The bit I want to focus on today is the kind of structural piece, right, of who, in this new three-tier government system, who is responsible for what. And the Constitution tells us a little bit about that, but there's an awful lot that it doesn't tell us. And that's where some of the issues have emerged and where some of the problems continue to be. So you can see there's a kind of federal level kind of national health policy, standard setting, and so on. But then there are particular responsibilities given to provinces to determine their own provincial level health policies, with the aim here that this can be more receptive to local health needs, which any of you who know anything about the kind of geography and demography of Nepal will know varies massively across different parts of the country. But also the new local governments are given really important responsibilities, especially for running kind of primary healthcare and running basic health services in their particular areas. There's a lot that's not explained in the Constitution, like who's responsible for what, and that's where lots of the issues emerge. So here's just a picture of what we end up with is this kind of three-tier structure where you've got the Federal Health Ministry. Each province then has its own Ministry of Health, or in some cases called Social Development. And then within the local municipality governments, you get health sections. Usually, in most cases, relatively small in terms of the number of staff working in those, but with really key responsibilities for local healthcare delivery. District health offices are a kind of hangover from the old system. They actually are not supposed to still exist under the provincial system, but they're still there. They're still there now formally under the control of the provinces. But we've still got, at the moment, 9 years after the adoption of the Constitution, we're still in this kind of hybrid transition stage from the old system to the new system, and districts have not yet disappeared, and it's not clear whether they're actually going to or not. Okay, so the transition process, and I think this is one of the things that is quite important to get across, is although the new constitution was agreed and signed in 2015, we're still very much in the transition process between the old system and the new one. The new governments at province and local level are now all up and running, but even that took a few years. But there's still quite a lot of negotiation and uncertainty about who's responsible for what, how the different lines of reporting, lines of control work between the three different tiers of government. Any of you who are following politics in Nepal at the moment will know there's quite a big debate about the role of provinces. Provinces is the level of government where people are not exactly sure what it is they're supposed to do. Some of the parties are currently proposing that they get rid of provinces, and this is an unnecessary extra level of government. So already, before the constitution's even fully properly implemented, there's already this kind of wave of rethinking about whether we need all of these tiers of government or not. COVID, in the health sector specifically, COVID-19 obviously massively interrupted this transition process, in some ways slowed it down, as you would probably expect. Although in some ways, I think actually did show some of the benefits of the new system, and immediately we saw local governments being able to take action kind of independently in a way that they probably wouldn't have been able to do before. But anyway, that's something we can come back to later. Finally, just about what can I talk about and what can't I talk about. We've really struggled in this project, and in fact, to the extent that we've given up, trying to demonstrate any very clear causal link between this constitutional change and actual health outcomes, right? And the reasons for that will be obvious. There's so much other stuff happening. To attribute, particular changes in life expectancy or maternal mortality or whatever that might be to this constitutional change is almost impossible, not least with the intervening factors of COVID and so on. I mean, what we can say is most of the major health indicators in Nepal have been improving during the period in which we've been working on this project, but they were also improving for quite a long time before that. So over the MDG period from 2000 onwards, Nepal did actually incredibly well in terms of the improvement in health indicators. That's not continued on anything like the same upslope, but those continuations have nevertheless been there. But we haven't got any good methodological way of linking that or any changes in that to the kind of changing of the constitution. Instead, what we're trying to do is look at how that's impacting on the way the health system is working, right? And indirectly, of course, you would hope that has an effect on health indicators in the medium to long term. But we're not making any claims here about particular changes in health indicators being linked to the constitution. They're very difficult claims to substantiate. So we're looking at how does the health system work. And this is a project which has been going for 4 years now. We started in 2020 at this not great timing, very beginning of the COVID pandemic. We started online for quite a lot of time, helped by the fact that we had such a fantastic team in Nepal who we'd worked together previously. So we didn't have to do all of that kind of getting to know you process, which happens at the beginning of projects. But nevertheless, the early stages were inevitably quite disruptive. Not least our ability to kind of take the time of people working in the health system to engage with our project, right? I mean, there were quite significant ethical dilemmas thrown up there. There's a whole series of institutions working on this. You saw the logos previously, some in Nepal, some in the UK, and a very big and very kind of interdisciplinary team, all of which is funded by the UK Health Systems Research Initiative. I'm not going to kind of go into too much detail on the projects. I'm going to talk a little bit more about the methods later, but just to flag some of the highlights. We were interested in this project about kind of looking at change over time from the adoption of the constitution through to now. We were interested in the kind of applied research where we can hopefully feed back into policy and practice and as we go along, right? So this is not a kind of project design where we do data collection, then analyze it, and then try to feed back into policy. We're actually doing that in kind of real time as we were going along. We were interested in the health system in the kind of broadest sense. Some of you will be familiar with the WHO health system building blocks, and we use that as a kind of framework for this study. I'll show you on the next slide what they are. And working at all levels of the health system in a kind of bottom-up way, right? So we started at the village level and gradually worked our way up through the levels of the system up to the federal government. And then the thing I'm going to come and talk about at the very end is the kind of participatory approach that we took in the project. So yeah, we did kind of traditional interviews. We used some of the quantitative data that the system collects. But actually the kind of main methods we were using were a kind of series of participatory approaches, particularly using participatory policy analysis workshops that I'll come and talk about at the end. For anybody not familiar, these are the WHO health system building blocks, the 6 of them. In some ways, it's quite a kind of reductive and simplistic model, but nevertheless, it's been one that's been quite useful for us in this project. So we're not only interested in service delivery, that's, I suppose, the kind of sharp end of the health system, but actually also interested in all of those back office functions that make health systems work. It's been quite a useful tool for us, both to make sure we're not kind of missing important parts of the health system, but also because it's the one that's very commonly used in Nepal. So in engaging with policy audiences, it's there in particular. It's quite a good way of identifying and engaging with people on different elements of the health system. All right, so 2 things I mainly want to do in the last 10 minutes or so before we open up for questions and answers. I want to just give you a kind of flavour of some of the findings the findings are like huge and diverse, and some of them are very locally specific things, and some of them are much more kind of national level things. So it was a bit hard for me to think about what to tell you and what was the right level of detail here. But I thought I'd just give you a flavour of it before I move on to say something about a kind of reflection about the methods. So let's start with the positives, because inevitably our projects focus on the negatives, which I guess is what you end up doing in research projects, but it's a shame if you only do that, I think. So I think it is worth just kind of briefly rehearsing some of the positive things we found. We've certainly found like increasing resource availability over time, and that's quite a significant thing, and something which lots and lots of people involved in the project as participants have talked to us about, especially at the local level. They're seeing more money available for health services, which means they're able to do more things in terms of provision of health services through primary healthcare facilities, but also kind of outreach in the community, public health programs, all of those kind of things. So there's a good news story there. There's also a good news story around, not universally, but to a great extent, around the new kind of locally elected governments, and how, you know, there's a general thing that they're much more responsive to the needs of the populations and care much more about health than the previous local governments did. So again, you know, there's a kind of good news story there, and a kind of burgeoning sense, I think, of kind of political literacy amongst the population, and realization actually that they can make demands of these locally elected leaders in the way that effectively they couldn't under the previous system. That's still undermined a little bit, and I'll come on to talk about this, especially at the federal level. There's still quite a kind of centralized mindset and a bit of a lack of trust in local government to be able to deliver, but nevertheless there is that kind of local responsiveness, and that comes out in various ways. So for example, local governments are able to hire health staff now in ways that they weren't able to before. It used to be that everybody was sent by the Central Ministry of Health to where you were going to work, whereas now actually local governments are able to think about what are the staffing needs in their particular areas, and in theory at least, to hire the workers they need. There's also what that leads to is much more accountability at the local level. I mean, any of you who worked in Nepal previously will know there was a huge problem of health worker absenteeism, particularly in more rural areas. So in principle, every village would have its health post, and every health post would have its health workers. But very often when you went there was nobody there. And that has really kind of decreased as a problem. And that's partly, I think, about local government actually now being much more effective at overseeing what's actually happening in practice. And we've seen a lot of building of new health facilities. We've seen that at the village level, with lots of local governments putting their resources into building new health posts, but also at the province level, we've seen the development of new hospitals. So there's a kind of general increase in facilities. So lots of good news. Let me go on to the bad news. And I'm just going to very, very briefly go through this, because we'll run out of time otherwise. But I just wanted to map some of the kinds of issues we've been finding against the different building blocks. Leadership and governance has been a kind of clear area where we've seen continuing issues and dissatisfaction. So quite often we've found local governments who, even if well-intentioned, are not actually that well equipped to manage health services in practice, primarily because they haven't received the training, the support that they would need to be able to do that. We've seen dynamics where the political incentives are often about creating new buildings and not necessarily actually delivering services from those buildings. So that's been a problem in many of the places where we've been working, where you get shiny new health posts, but not necessarily the staff or the equipment or the medicines to actually make those things work. I've already mentioned, especially at the federal level, you hear a lot when you talk to federal level people of kind of dismissiveness about the abilities of province and local level governments, a kind of yearning for the past where the experts in the central ministry were able to control what was happening. So there's some resistance there. The lack of clarity about the province role I've talked about already. Very often there's a lack of certainty about what it is they're actually supposed to be doing. And then as you get in all federal systems, Nepal's not unique in this, you get these turf wars between the different levels about who's paying for what, who makes decisions over what, how the money is supposed to flow. Service delivery, I'm just going to do a couple of very brief things here. One, and partly just to highlight some of the things that we're doing at the moment. So health facilities have these health facility organisation and management committees that are supposed to oversee the running of each health facility. A lot of those are not performing very well, and part of what we're doing as a project at the moment is rolling out a kind of training package for those people who are partly health professionals, but partly community people and partly local elected officials who have been given the job of overseeing these health facilities without actually being told how to do that job. So there's a kind of training package that we've been rolling out. There's quite little monitoring happening of service quality. So there's a lot more monitoring happening of service quantity, but not very much happening in terms of service quality. Lots of issues continuing over financing. So although, as I said, the overall amount of money is increasing, a lot of that comes down to local government in earmarked funds, which is not necessarily how they want to spend that money. So the centre's kind of maintaining control over some of that stuff. Very often money's arriving late at the local level, but also a massive problem of underspend of budgets at the local level. And again, that's partly about local governments not really knowing how to spend their budgets and certainly how to spend them effectively. Human resources, again, huge problems there, most of which predated the constitutional change. These are kind of ongoing systems, but it's really hard to get staff to go and work in rural areas. And again, you know, Nepal is not unique in that, but to attract and retain staff is really difficult in rural areas. So although local governments in principle now have the ability to hire people, in practice, they very often can't. And there's a huge number of vacancies. At the during the transition to the new federal system, they had a process which was called staff adjustment, which was supposedly about moving staff around the country to where they were most needed. But in practice, what that's ended up with is quite often people's not without the right skills being in the right jobs, and also on the other side, kind of people with skills being in jobs that are not fully using those skills. So there's some issues there. Around medicines, the system for procuring medicines has become massively complex. Used to be everything was bought centrally and then distributed. That had challenges, right? And quite often medicines and other equipment weren't reaching the places they were needed. Now you've got procurement happening all over the place. You've got local governments procuring their own stuff. You've got provinces procuring their own medicines. You've got central government still doing stuff. So there's quite a lot of kind of inefficient duplication of effort, but also some evidence that's leading to rising costs and kind of reducing economies of scale. And then around information systems, that's still a bit of a mess. In terms of the data quality, but also in terms of the kind of training that staff have at the health facility level to be collecting and reporting that data. Okay, so very brief. We can go into some of that detail later. I want to just very briefly in the last couple of minutes just talk a little bit about the methods and particularly about participatory policy analysis, which wasn't something we invented. But it's something that hadn't been used that widely in health systems research before. We nicked it from it was quite fashionable in agriculture in the 70s and 80s. That was where we not nicked it. We were inspired by some of that work. And we were quite keen to use it in this project for a variety of reasons, partly to get away from this kind of outside experts coming in and telling people how the system ought to work kind of approach. We actually wanted to work with people who were at the kind of sharp end of these changes and who were actually in their kind of working lives experiencing these changes. And actually, you know, our view from the beginning was that those people working in the system were the experts on how this constitutional change was affecting the system, not us. So we were very keen as a kind of ethical approach, I think, to work with them, but also to make sure we were talking to a very wide range of different people. And that's really been borne out, I think, is talking to health workers on the ground, talking to female community health volunteers who are often doing a lot of the heavy lifting at the kind of village level, you get a completely different picture to when you talk to people in the federal ministry. Absolutely like two worlds in terms of what's going well and what's not, and what the impact of this has been. It's meant that as researchers, we've been in a much more a kind of, I suppose, kind of facilitating role, and in terms of like we've designed the research questions, we've designed the project, but actually a lot of the analysis have been done by the participants themselves, and we've used a series of methods, which I don't have a lot of time to go through in detail, to try and prompt that analysis and to guide the participants in the workshops we've been doing through a process of them actually analysing what the impacts of federalisation have been on the health system. There's a link there at the bottom to a paper where we've reported some of that work. I might skip through a little bit of this, but we've done a whole bunch of these workshops at local level, provincial level, but also bringing together the different levels of government. And one of the nice things of that has been actually quite often what's happened is bringing people together in a room that just never sit in a room together to talk about how this is impacting on the health system and how this is impacting on their kind of professional practice and their daily working lives. I won't go through this, but this is just intended, I think, to give a kind of sense of the diversity of people who we've been engaging with. So both health system people proper, but also political people at all levels, and bringing those together in ways that, again, has been quite interesting. I'm not, I've skipped on two there. I'm not going to go through this in any detail because I've already talked for too long, and you can follow up on the paper that was in the last slide if you want to look at this. But in these workshops, so one-day workshops, we basically worked the participants through a series of 3 different exercises where we're getting them to reflect on the federalisation process and how that's impacted on their working lives individually. And we use a variety of kind of really well-established participatory formats for doing this. So we didn't invent any of this stuff. We just kind of put them together into workshops. So we use this activity, the River of Life, to get people to think about change over time in their own working lives. We got in small groups people to think about the problems that have been thrown up by federalisation and what kinds of impacts those problems have had, and then to prioritise those. So over the 30-odd workshops, we got like literally hundreds of different projects, which small groups then dived into in more detail through. A lot of you be familiar with this kind of exercise, using problem tree analysis to try and dig deeply into those individual problems, thinking about what the causes of them were, thinking about what the impacts of them were. But then in a next step, working from there into creating action plans about what can be done about these problems. So at the end of each of the workshops, small groups worked on, okay, so we've analysed this problem collectively, what can be done about it as a group? And sometimes that might be things which people could take forward themselves in their own working lives. Sometimes it was advocating at higher levels for policy changes. Sometimes it was things that we as a research team were able to take forward on their behalf. Sometimes it was things that they identified who would be the appropriate people to take this forward. So at the end of each of these, each group came up with a kind of action plan of what were the next steps, and we can talk a little bit more later about what came out of those if people are interested. I want to end. Oh, we've got a raised hand. I wanted to end just with, I suppose, some reflections on the kind of pros and cons of this as an approach. And these are, again, quite high-level reflections, but I'm very happy to talk in more detail about these later if people would like. I mean, the first thing that we were kind of relieved by was quite an amazing level of engagement with people with this process of participatory policy analysis, especially at local level. People are actually really keen to be involved in this and saw this as an opportunity to kind of get their voices heard, but also to be able to generate momentum for change, I think. That might not work everywhere. I mean, Nepal is quite a kind of conducive political context for this. I think people are not scared of criticising government in Nepal. It's a very kind of hierarchical society, and lots of those kind of power relation issues, which I'll come on to into a minute. But people are not kind of fearful of critiquing how things are working and putting forward their ideas for change. We definitely got a much greater depth of insight than we would have got through kind of traditional qualitative interviews, focus group methods. And by having such different people in the room at the same time, we were really able to get people to kind of argue out their different perspectives in a way that was really revealing. We were able to bring technical health people and political people together in combinations that doesn't normally happen. And again, here in real time, their kind of discussions over the issues. We're working in a number of different places across the country. So we were also able to kind of identify both common problems and site-specific problems and to proceed on both of those differently. And as I've already talked about, those kind of action plans, this was quite a nice way of thinking about how can you take these research findings forward and actually kind of create change on the basis of them. Nevertheless, some of the negative things, I think this is the very last thing I'm going to say. Gatekeeping in terms of attempts to control who was in the room and who wasn't by local government was a thing that was quite often faced, and is certainly not unique to our project. And then once you've got people in the room, those power dynamics, which take a bit of getting around in terms of who gets heard, who's most confident to speak, whose ideas get taken most seriously, and our Nepali colleagues were able to do some amazing facilitation work to mitigate some of those power dynamics, certainly not to remove them. We definitely, and this is where some of the kind of, especially when we've spoken to higher level people, some of the critiques of our work come from is you get like partial answers from people, right? You get people talking from very individual perspectives, which are not necessarily representative of they're certainly representative of something, but they're not necessarily representative on a kind of national scale. So that's, of course, something that you have to be wary about. And again, a thing that I think we've really faced as a team is the kind of danger of raising expectations, and not unique to our project, true, I think, of probably all health system projects in lower resource settings, but especially when you're working in a participatory way and taking, really getting lots of people's time and lots of people of engagement and kind of emotional investment in the project, to be realistic about what the results might be is actually quite an important but nevertheless challenging thing. So the idea that we as foreigners can make things happen just by taking forward policy recommendations is one that sometimes we came across, and is obviously not true, and neither should it be true. But being realistic with participants about what can be achieved. All right, so I think I will stop there. Sorry for speaking for slightly longer than promised, but hopefully we've still got a bit of time for Q&A. I'm very happy to talk about the project itself, but also to engage with people either on the empirics or on the methods, whichever's of most interest.